Robert's going to talk to us about ketamine-assisted psychotherapies. Thanks very much.
Thank you very much, Philip. And I'm sorry to be the next speaker after Jerry, because I think this was really a very thoughtful lecture, and I think we can go on discussing this for the rest of the day or the rest of the conference, because it touches upon so many things that are extremely relevant. But still, and I think being the next in line, you will see there's a lot of overlap. So maybe that we can use that also for the discussion. These are my conflicts of interest. Mostly I'm funded by public research funds. I present this work, we did this together. We tried to synthesize the literature on psychotherapy, so ketamine-assisted psychotherapies. It is very broad, and we are still putting it together, so it's sort of work in progress, and Jolien, who's sitting here, is one of the persons doing that hard work. Ketamine is a promising treatment with repeated administration. Effects may wear off. Ketamine-assisted psychotherapies are believed to prolong treatment effects and add psychological gains. Preliminary results are promising. However, do we understand the specific benefits, the rationales, and the working ingredients? And that was sort of what we set out to find in the literature. And before I embark on that, I briefly present the work of Joost Breeksema, who did his PhD 2 weeks ago. He interviewed a lot of patients in our ketamine and psilocybin studies. One of these was presented at a previous conference. Basically, and the latest, we specifically explored what patients would tell us of their experiences and how that would sort of be something that we could use for psychotherapeutic purposes. And for those of you who have openly discussed with patients what they experienced, you know there's a wealth to work with. So, for example, the overwhelming anxiety, the more like horror experiences, or the feeling of being completely gone, or the K-hole-like experiences. It's really a very rich and sometimes frightening experience. People also experience openness to whatever happens in the room, but also openness to what's in their mind, in their conscious or maybe subconscious experience. And they are able to look at that with less immediate emotion, we hope. And that speaks to the detachment. So you can make different ways to present it, and you can describe the phenomena in different ways, but I think everybody who has talked to people using ketamine will recognize that what we may call side effects or dissociation may be the most meaningful experience of the whole treatment. Not necessarily, but there's quite a number of people who would tell us that, which speaks to Jerry's presentation also. Looking at the literature, we wanted to provide an overview of the clinical studies. We wanted to describe the psychotherapeutic strategies, and we wanted to search for the specific elements. So what are the ingredients and why do they work? We did a systematic literature search, and we looked for studies that did not only do support, but that had psychotherapy in whatever form. We find 49 papers published between 1973 and last year. And as you may imagine, a whole range of different indication, treatment regimens, dosage, combinations, everything is there. And I'm going to present it in a historical order. Not very surprisingly, it started with more psychoanalytically oriented therapies. Narcoanalysis, cathartic abreactions. So by inducing a state of relaxation, and you might elicit repressed information, sort of opening the unconscious. And also there was a lot of interest for abreactive responsive. So attaching a very negative feeling to something you don't want the patient to do anymore, like use drugs or use alcohol. Rocket, who has been described in Cover Story, it's a podcast about psychedelics that I think it's worth listening to. Maybe if talking about how you influence this, can I get this going?
It's slow. It works, but...
Okay, well.
Which one have you got? So that one there.
Yeah.
Okay, that has the pointer. This one.
Yeah, but I don't know if that.
So that, or you can use this one, which has a top one there, and you point it. And it takes a while to come. That's the best way to use that one. It's
I'll see, and otherwise,
yep.
No, it's not working. I can recommend listening to it. Imagine you're lying on the floor, lights are flashing and projectors are playing movies on all the walls. The Mexican psychiatrist Salvador Rocket has given you LSD, maybe mescaline. You're tripping your face off. The projectors start playing porn and murder and war scenes from the Dirty Dozen, etc., etc. Already psychedelics may induce an overwhelming experience, and this is overwhelming plus. This is no longer practiced in that way. It was practiced for quite a large number of patients. So there's at least 2,000 patients described, of whom 83% supposedly has improved and with very little negative effects. And then an era came which sort of uses elements from that which is called effective contra-attribution. It was started in Russia by Krupitsky, and it was used for alcohol use disorder, and the idea was to attribute negative psychedelic experience to alcohol use. Experience of death and rebirthing, isolation, catastrophe, and it was relatively effective when you compared it with treatment as usual. From that, because the aversive therapies were maybe not as effective as when patients had more positive experiences linked to the things they wanted to achieve. So that sort of changed to psychedelic therapies with high doses that were aimed to produce altered mental states, to open them up to a more reflective and vulnerable states. And there's a whole range of papers done with it. I'm going to talk about the quality of all of this later. Interestingly, and probably not surprisingly, more sessions and higher doses yielded larger effects. This was also done in more intensive therapies, in group sessions. And then I found it very interesting. So this is Kolb, which is a colleague from Krupitsky who did his studies in the US. And when the individual or the intensive therapy wasn't effective, he started adding additional elements. So first of all, he selected patients without prior psychedelic experience because he thought that people needed to have a novel experience in order for it to maximally work. And then he started adding extra weeks of therapy, additional group therapy, life skills training, substance use education, etc. He also noted that there were personality characteristics of patients who were less likely to respond. But there seems to be also, in adding more elements to the therapy, some sort of a dose-response curve. And for those of you who don't know, the psychedelic is usually the high dose, so the transformative experience kind of therapy, and the psycholytic is the lower dose where you use it during talk therapy and where you sort of lower the defenses, but people are conscious during the whole sessions. And but it facilitates the psychotherapeutic discussion. And also that was found to be to have relatively good results, but at much lower doses and also with different approaches. And then psychoanalytic, psychedelic, psycholytic. What happens in time then? We go to the cognitive behavioral therapies. So we do this with ketamine treatment. So we went to the CBT-based techniques: exposure, response prevention, cognitive restructuring, all of it. And CBT was usually administered a day or days after ketamine sessions, so not during. And the idea, of course, is the narrative that Jared also discussed of increased neuroplasticity, the window of opportunity for psychological interventions. We tell it to our patients. I mean, and also, if you look on a more mechanistic way, it may be that ketamine increases the effects of extinction learning and lowers fear renewal, of course, which are, for example, with severe anxiety disorders, are really something. The combination may further increase synaptic plasticity. The top-down effect on anxiety is associated with the amygdala response, and also totally different aspect in these treatments with a psychedelic or with ketamine. Sorry, all of this is about ketamine. It also helps the therapeutic relationship, and the therapeutic relationship is a major factor in making CBT effective. And then we move to the third generation CBT techniques. They're listed here. I'm going to give a few examples. So the mindfulness-based, the trauma interventions using mindfulness-based, and for example, studies in cocaine-dependent users, and where they combined mindfulness-based relapse prevention, integrating it into daily life, and this was added to this structure was one session of IV ketamine versus midazolam. And I'm going to talk in the discussion about whether these were RCTs. This was an RCT in which ketamine versus midazolam was blinded, and it was found that ketamine produced lower likelihood of cocaine use, less craving, longer time to relapse, and this remained for 6 months, one infusion plus CBT. And also the other study found that the ketamine had a sort of beneficial additional effect to the CBT outcome. And then I'm not going to go very deep into that. So most recently, as the field of psychotherapies is also advancing, we are now moving to somatic psychotherapy, telehealth, ACT, emotion-focused therapies. And another interesting project, the community of practice approach, with sort of eclectic group sessions plus a combination of ritualistic ceremonial elements which come from the psychedelics, the retreat-like influences. And it also had very positive outcomes. So, what to make of all of this? First of all, you can say that there's in the literature there's a large number and a wide range of psychotherapeutic approaches. And you can also say that the forms of psychotherapy vary over time and appear to represent prevailing approaches of each era. It sort of very nicely follows where the field is. Unfortunately, the studies are mostly descriptive, and the overall methodological quality, if you want to see what works better than something else, is low. And of course, that's a problem if we want to tease out what are these specific elements. There's a lot of heterogeneity in ketamine formulation, in dosing regimens, in patient populations, also in the level of detail with which the psychotherapeutic interventions are described. So if you label something as psychoanalytic, what actually do you do? Or if you label this as CBT, what do you do when you are with the patient? There's differences in psychotherapies that are provided during or after the administration. And I think that the main message, it's very hard to disentangle ketamine versus psychotherapy and other influences. A number of studies, about 1/4 of the total, did try to make direct comparisons. So they were straight or not so straight RCTs. For example, the Krupitsky studies, in which they compared ketamine-assisted psychotherapy with treatment as usual, and there they found that ketamine outperformed treatment as usual, which is relatively sound. Mindfulness-based therapies appear to be better in abstinence, relapse, craving, and dropout, in combination, I mentioned, with ketamine versus all of this with midazolam. And then there's basically, as far as we could find, only one trial with control groups for the ketamine intervention as well as a psychological placebo. Basically, you would like to have controls for both, so you get 4 arms. And that, of course, you need huge numbers. But Grabsky et al. Were so courageous to do this. And they found that ketamine outperformed saline control, and a mindfulness-based therapy outperformed education, suggesting synergistic effects. Timber also showed a longer duration of response, and another study comparing CBT to treatment as usual did not find a significant difference in the primary outcome, but they did find it in the secondary. So you could say that in these studies, at least, they really did their best to tease out the different elements and to see what works better than what. And then ketamine has an addition to the overall efficacy, and the psychotherapies that were studied appear to do a bit better than treatment as usual. Well, all of this may not be very surprising, and all of it may be due to the team being more enthusiastic and all of those aspecific factors. Are we looking at common factors? And what would they be? First, you might say that ketamine strengthens treatment engagement and therapeutic alliance. It lowers defensiveness. It may help gain access to traumatic memories. This is not proof, but these are sort of thoughts looking at this whole literature. They may evoke transformational peak experiences. They may facilitate psychotherapeutic interventions. They may lead to increased cognitive flexibility, and they may help look at difficult things in a more detached way. And all the treatments had attention to preparation before the session, set support often during the session, being mindful of the context, and they had some form of integration. So, Gerald, is this another Dodo's verdict? I'm sure most of you have heard of it. This is sort of the main problem of all kinds of psychotherapies. If you do something, it usually helps. Only it's very hard to tease out the specific elements and to prove that one approach is better than the other. So you could say, no wonder that it was very difficult if you review the whole literature that we didn't find very specific elements. Well, you can say that's a good thing because maybe they're just not there also when you compare it with ketamine. This is our research group, at least part of it, and thanks to all of them, we did this work. Thank you.
Well, thanks very much for a fantastic survey, Robert. Are there any questions? Oh, quite a lot. So, yes, let's start at the back there.
Thank you, Robert. My name is David. I'm a big fan of the work that you've done. I cite Jost's publications all the time, and really appreciate you going through an overview of so much information. And piggybacking on Jerry's presentation earlier too, I'm just so stunned by the fact that we say 82% of this effect is non-specific, and see that not nearly reflected in sort of our funding priorities and what we're really trying to research, what we're trying to optimize. When we think about non-specific drug effects, I think it's easy to reduce this to placebo, and maybe, this came up with Teresa's conversation as well, when so many of these factors are things like meaning, growth, imagination, that are in that territory, sure, but also in the territory of psychotherapy research. I'm just trying to imagine a path forward where there is equal or maybe even the attention based on these numbers for these kinds of studies and this kind of work going forward. And not an easy question, but I just ask you, can you see a path forward where there is more emphasis on that, and what would that look like?
I was hoping you were not going to ask that, but thank you very much. Well, I think, as Gerald was saying, we would be, I don't know if that's an English expression, we have an expression, throwing the baby with the bathwater.
Yeah, that's a lot.
Okay, so if we say that all of this placebo, aspecific, contextual is meaningless, we sort of throw out 3/4 of the meaning that we and patients invest in treatment, and it also helps. So how can we be mindful of the fact that this is not specific, but it is still important? Jerome Frank says a rationale also helps, because if I'm a clinician, I need a good rationale that I can discuss with my patients, and if this clicks, the result will be better than if I don't believe the rationale and the patient doesn't believe it. So, and how to integrate that into daily clinical practice, I think as people who work with residents, is something you encounter very often. You see big difference also between clinicians in how they work with patients. Studies that have compared the efficacy of clinicians in clinical trials also show interesting differences. So I think we can invest in our own clinical capacity. I think really that's important. Patient manners, looking for how to really make contact, to develop your empathy. It should be there, but you can develop it further. And then whether the whole research field should be this focused on the specific elements, I think that's really open for debate. And I don't know if an answer, what would then be the best direction. I think that we could organize a conference about that. Gerald.
I just had one thing to say, and Celia's not going to love me for saying it, but actually you're wrong to say that in her study, in the Grabsky study, that the psychoeducation and the psychotherapy were that the psychotherapy was better than the psychoeducation. It wasn't significantly better.
Okay. Excuse me for
wide
that.
myth. Sorry.
Someone right next to you.
Thank you for the talk. I was curious your opinion on, there's this whole industry that's developed in the United States, at least, around this concept of ketamine-assisted psychotherapy, where there's these organizations that will charge a lot of money to train therapists to do, and it seems like it's kind of this experiential-based, transformative therapy that you're discussing, maybe more dynamic oriented, but there's really no evidence behind it. It's just they're kind of standing up these programs and selling it to people. I'm curious what your opinion is on that and how we would go about approaching that or studying that.
Yeah, it's a great question. If you consider the Dodo verdict, then it's likely that it will have a beneficial effect if you know what you're doing as an experienced clinician. However, if for funding purposes, because this is most probably all done by people paying out of pocket, right? So if this has to enter an insurance policy scheme, then they have to come up with evidence of efficacy, just like all the other treatments that are funded. But I would imagine that the efficacy in a well-organized setting would not be much less than competitors.
I'm sorry, I think we ought to move on for
Yes,
time. But
okay.
Thanks very much.
Thank you, Martin.